Good day, everyone. Today we're going to talk about the documentation process in the inpatient mental health setting. My name is Kevin McDonald, and I'm an occupational therapist working in Regional Hospital in Scranton, as well as its sister hospital, Moses Taylor, in the Senior Mental Health Unit, also in Scranton. We provide care for inpatient mental health patients, typically over age 50. A little background information for you. About 1 in 5 U.S. adults live with mental illness, ranging from anxiety and depression to bipolar, schizoaffective disorder, and psychoses. Many of these individuals may require inpatient hospitalizations to ensure that they receive the proper care to get them back living productive lives again. Occupational therapists play an important role in inpatient mental health care setting. We typically work as part of a comprehensive care team, which includes psychiatrists, general practitioners, nurses, physical therapists, caseworkers, aides, and activity directors to provide individual and group therapy to address mental health issues. Of course, we also work with patients to address other issues they want to work on, such as ADLs, mobility, and other physical conditions. We already know that occupational therapy works to help individuals regardless of age, gender, race, sexual orientation, level of ability, or mental acuity. We help people because they have some limitation they want to work to overcome or find more satisfying ways to live with. Documentation in this setting is a little different from acute care, inpatient, or outpatient because we're working with a population who may have unique needs, diagnoses, behavioral patterns, and abilities. Of course, working with a unique population means we have a unique set of rules for documentation. Let's take a closer look at what we have for this lesson. Our learning objectives. We're going to analyze documentation for inpatient mental health patients and how it may be different from other forms of documentation. Secondly, we're going to reflect on and develop your documentation style that creates concise, professional, and appropriate mental health inpatient documentation. In addition, the following Accreditation Council for Occupational Therapy Education standards will be addressed. I'm not going to read each one of these, but they include a demonstrated knowledge of documentation, care coordination, and evaluation mechanisms in the mental health setting. A little background on the inpatient mental health setting. For those who may not be familiar with this setting, please put aside anything you may have seen in movies about what a psych ward may look like. Hollywood is not accurate, it's not even close. In fact, the typical inpatient mental health care setting looks much like your average hospital. There are individual patient rooms and day rooms for watching TV, enjoying activities, and playing games and puzzles. And they have their own dining room. The biggest difference is there's a locked entrance. So what is a typical patient like? Well, I'm not sure I can answer that question. There is no typical patient in any setting, but I can tell you again, put aside the Hollywood caricatures. Many of these patients are just like the people you walk by on the street every day, or pass in stores, or say hello to when you go to pick up your pizza. They're just like every people in our daily lives. Typically, we see most patients just have an uncontrolled degree of anxiety or depression. Certainly, others can carry a diagnosis of bipolar disease, which, as you know, means they're unable to function independently because they're very depressed or very elevated mood swings. In addition, there's schizophrenia, which is characterized by auditory, visual, or tactile hallucinations, delusional thinking, and disorganized behavior. Schizoaffective disorder, which is schizophrenia with an accompanying mood disorder such as depression or bipolar. And psychoses, the inability to determine reality. These patients usually require a greater degree of inpatient care. Keep in mind, we still work with these patients to provide interventions that address deficits with activities of daily living, mobility, and any living skills the patient may want to address to help them live independently. Patient stays range from just a few days to several months. Of course, conducting group sessions is where OT really shines. Occupational therapists provide group sessions to help individuals address their mental health. What are some of the group sessions we present? Groups are typically 40 to 60 minutes in duration and present a wide range of topics, such as recognizing and living with anxiety and/or depression, problem-solving skills, coping skills, self-esteem, goal setting, recognizing stressors, social interaction skills, interpersonal relationship skills, developing appropriate leisure activities, and building confidence. Oh, the photo? That's not actually an OT group, but it's a cute group nonetheless. So let's talk about the American Occupational Therapy Association's general guidelines for documentation. You may be familiar with some of these guidelines from discussions in previous classes, but I think it warrants some review here. The screening. The initial screening of a patient begins with receiving an order from a physician who requests occupational therapy services. That request includes the patient name, date, and reason for the request. The initial screening includes accessing the patient's electronic medical record, also known as the EMR, which includes all known and pertinent patient information. There's usually an admission note that includes the patient's history and physical examination, also known as the H&P. As it sounds, the H&P provides insight into the patient's medical history, including any medical conditions and the current sequence of events that brought the patient to our facility. The H&P will mention if the patient was a voluntary admission or has been brought under 302 guidelines, which means a qualified professional such as a physician, another health professional, a counselor, a public servant such as a police officer, believes that this person is a danger to self or others. We see this often with individuals attempting to or threatening suicide, and with some people who do not have the cognition to care for themselves independently. The H&P may also provide insight into the patient's background and home life. If not, we'll gather that information at the time of the evaluation. The evaluation. The evaluation is more formal and structured. We provide an analysis of occupational performance for the patient, just as we would for an acute care patient. We test their range of motion, their muscle strength, bed mobility, ability to perform sit to stand, and the ability to mobilize. In addition, as a facility requirement, we take the patient into their own bathroom and discuss bathroom safety, including the use of grab bars and call bells if they need assistance. We must also make sure we take good notes during this process, so we can formalize the information in the EMR later. Be sure to listen to the comments the patient makes, and how those comments may impact their occupational performance and goals. As part of the evaluation process, we also ask a series of questions about their background. For example, we ask who they live with, if they use a walker or a cane, what the physical setup of their house is. In other words, is it a one-story house or a two-story? We ask if they know why they are admitted to our facility. Many don't or won't admit it, or they minimize the situation. Specifically, we also ask, what is the reason for admission? Do you know why you are here? We check on their stressors. Was there anything causing more stress in your life lately? We ask for a personal strength. What is a personal strength of yours? What are you good at? We ask about their weaknesses. What is a weakness? Something you would like to improve about yourself. We ask about their leisure time. What do you do in your free time? And we ask if they have a goal. Do you have a goal while you're here? Something you would like to accomplish? We also perform the SLUMS. The SLUMS is the St. Louis University Mental Survey, and it's a free assessment that measures a person's cognitive ability. The SLUMS is reportedly more accurate than a mini-mental and is quite easy to administer. I have included a copy of this test here. and I strongly suggest you copy and practice using it. Try it on each other. It can be fun at parties. Conveniently, the EMR makes charting easier than charting on paper. All the coding and billing reimbursement is calculated within the confines of the technology, making it easier for occupational therapists to simply focus on the patient's performance and how we can improve their lives. Within the EMR evaluation, there are areas for all the information gathered during the screening and evaluation. This is where we set the course for the patient's care. In our EMR, there is no specific location for writing one SOAP note. Instead, the EMR has a defined area where each element of the SOAP note fits in. For example, there is a subjective section that's included in the initial page of the EMR, where background information is listed. Subjective comments usually include a statement made by the patient during the evaluation. In this section, a typical subjective comment may be, "The patient reports feeling more anxious over the course of the past few weeks. She said she felt on edge and out of control." The objective statement is typically an observation or observations made by the occupational therapist and may include opinions based on the events and comments during the evaluation and personal interaction with the patient. For example, during the evaluation, patient had poor eye contact, was hyperverbal and tangential. She required redirection to focus on topic. She appeared to be minimizing her situation, describing a medication mix-up for her only reason for needing to be admitted. The patient described a fear of losing her apartment if she didn't leave to pay her rent. Patient reassured that our social workers will work with her and her landlord to secure her apartment. The assessment. The assessment portion of the note is where the occupational therapist provides a brief justification for professional services and interventions. It may look something like this. Based on the evaluation and observations, the patient will benefit from occupational therapy services to address increased anxiety and bipolar disorder. The plan section includes how the occupational therapist will address the patient. Generally speaking, this section prevents what interventions or professional approaches may be used. For example, recommended that patient attend occupational therapy daily to treat anxiety and bipolar disorder through group therapy and possibly one-on-one therapy. Also recommended that the patient try meditation and other mindfulness techniques to address feelings of anxiety and depression. Goals. Another important part of the patient's record is establishing goals. In the mental health setting, there are two types of goals we tend to look at. Goals that address physical limitations and goals that address their mental health care. Our EMR provides defaulted physical goal possibilities to address limitations with eating, grooming, upper body dressing, lower body dressing, bathing, and toileting, which are typical ADLs. The EMR also addresses mobility issues, such as bed mobility, sit-to-stand transfers, and the ability to transfer to and from a chair. Typical goals in this section may include patient will be able to don and doff socks independently by discharge. Patient will be able to perform sit-to-stand from chair with minimal assistance by discharge. Patient will perform grooming tasks such as standing in front of a sink with setup assistance by discharge. Goals that address mental health concerns are a little different, as you might imagine. We'll need to address the patient's behavioral, mental, and cognitive situation. Goals may include patient will improve coping skills by demonstrating 2 methods or actions she can take to reduce her anxiety by discharge. Patient will improve interpersonal skills within 1 week. Within 2 weeks, patient will develop 1 personal goal to achieve in 1 month and 1 personal goal to achieve in 6 months. We can also create goals for demonstrating brighter affect, identifying personal stressors, problem solving, self-esteem, decision making, and any others we need to do. Discharge planning. Although we do not recommend a specific discharge location, we may suggest that a patient may or may not appear to be appropriate to live without assistance. We speak with case managers and social workers and share our opinions about how the patient performs, but ultimately, the case manager and the physician decide the most appropriate level of care after discharge. In the discharge planning sections, we may write something like, "Patient does not appear to be able to live independently. Assistance may be required for safety." Group notes. A group note is a different but very important aspect of documentation. Since each patient attends a group session every day, we do far more group notes than any other kind of documentation. These notes also need to be clear and paint an accurate picture of the patient's progress and current situation. The group note is like a snapshot of where the patient is in the course of their treatment right now. So what is a group anyway? To write the group note, we must first talk a little bit about what a group session is. You may have seen on TV or experienced in some other way a group of people sitting in a circle talking about their problems. Alcoholics Anonymous comes to mind. That's kind of like what our group sessions are like, but not exactly. Yes, we all sit together and up to about 12 people in one room, but on comfortable chairs and couches, not folding chairs in a basement somewhere. We try to make our groups as inviting as possible. Patients are strongly encouraged to attend by physicians, but patients sometimes refuse to attend. I'll talk more about that later. Groups cover a host of topics to address patient goals, as I mentioned previously. I conduct group sessions on problem solving, coping skills, self-esteem, addressing anxiety, depression, providing positive outlets, mindfulness discussions, and the power of positive thinking. I try to make groups fun, make patients laugh, and encourage them to open up in a safe and supportive way. I really can't express how rewarding it is to hear a patient say that group sessions have changed their lives and made them feel that life is worth living again. Group sessions truly create a bond among patients in a helpful and caring way, and I've been given a great gift to be a facilitator in these sessions. When we document a patient's progress in a group note, we look for different aspects that may be less important to a traditional acute care or outpatient setting. For example, we are mindful of the patient's affect. What is the overall outwardly observable emotional state of the patient? We consider their behaviors. Are they seeking attention, or are they quiet and withdrawn, intrusive, talking over others? Do they seem annoyed? Their speech patterns. Do they have pressured speech? Are they hyperverbal? Are they not speaking? Are they tangential or circumstantial? Do they have a flight of ideas, or is there self-talk involved? Eye contact. Do they have no eye contact, partial? Are they staring? Are they appropriate? Interactions with others. Do they interact with their peers? Do they only interact with select peers, or no one, or staff only? Anxiety. Do they seem anxious or tearful, depressed or sad or worried? What is their attention like? Are they preoccupied? Are they settled on deep thinking? Are they being appropriate? Is their conversation focused or fixated on any particular topic such as religion, death, sex, a particular person or event? It's actually very common. Other questions or observations? Do they seem suspicious? Are they hallucinating? You can ask. Are they preoccupied, depressed? Are they elevated, agitated, drowsy, attentive, cooperative, or do they seem manipulative? Are they disheveled or angry, or do they seem neat and appropriate? And what's their participation level? Do they offer spontaneous comments, or do they speak only when spoken to? Are they conversational or quiet? Try to remember all of these things about the patient. I know it's a lot of information, but you get good at it the more you do it. So let's take a look at a case study. Donna is a 72-year-old female who was brought in on a 302 basis by a constable. She was found by a neighbor to be living in filth, disheveled, unkempt, unshowered, and malnourished. She was 302'd based on failure to thrive. She has a history of major depressive disorder and schizoaffective disorder, which includes a previous inpatient admissions. She stated that she has not taken her meds in several months because she no longer has a ride to the pharmacy. She stopped going to the doctor and her prescriptions ran out. She maintains a flat affect and does not make eye contact. She looks down at the floor while speaking in a soft voice. Donna has a son who lives out of state and calls her monthly. She lives in one side of a duplex home with no one living on the other side. She does not use a walker or a cane. She reports having a previous addiction to alcohol, but stopped drinking many years ago when her husband passed away. She reports hearing voices that tell her to kill herself, but she has no intention or plan. She fears that she can no longer take care of herself. Let's take a look at Donna's evaluation. Upon the initial OT evaluation, Donna demonstrated that she is independent with bed mobility, sit to stand, ambulation, and actual and simulated ADLs. Her manual muscle test and her range of motion are all within normal limits, and she's fully capable of performing ADLs and functional mobility. Although she requires cues to care for herself, she lacks motivation. We ask who she lives with. Does she live in a house or an apartment? Is it one story or two? How many steps inside and what side is the handrail on? How many steps on the outside of her building and what side is that handrail on? Does she use a walker or a cane or a wheelchair or any other assistive devices? Does she take care of her ADLs? Her evaluation revealed her reason for admission: my medications need to be adjusted. Her stressors: I'm tired a lot. Her strengths: I'm a nice person. Her weaknesses: I don't drive anymore. What does she do in her leisure time? I watch TV. What is your goal? To get my meds straightened out. She took the slums and scored a 17, which indicates dementia. By the way, the scoring key is on the bottom of the slums assessment. It's very easy to follow. So what do we do with this information? What does this information actually tell us? Well, Donna has failure to thrive and is not in compliance with her medications. And at this point, she is a danger to herself, especially with the auditory hallucinations telling her to hurt herself. She is physically capable of caring for herself, but she chooses not to. She does have a history of depression, schizoaffective disorder, and requires medication oversight for care. She does not have a stable home life, does not have supportive family, friends, or a social network. She does not have appropriate interactions with society. She cannot access the services she needs, like groceries, going to the doctor, or the pharmacy. She's had previous addictions and suffered significant grief. She also minimizes her problems. She does not have appropriate leisure activities, goals, or social interactions. So how do we document this? There are sections of the EMR where we add her background information, home setup, and observations. Specifically, for the subjective, I would include something like, the patient reports that her medications need to be adjusted. For the objective section, I would write something like, during the evaluation, patient had poor eye contact, was soft-spoken, and needed encouragement to answer some of the questions. She appeared to be minimizing her situation, describing a medication problem as the need to be admitted. She requires supervision to perform her ADLs and cues as reminders to care for herself. In the assessment section, I would write something along the lines of, based on the evaluation and observations, the patient will benefit from occupational therapy services to address major depressive disorder and schizoaffective disorder. The plan recommended that patient continue occupational therapy daily to treat major depressive disorder and schizoaffective disorder through group therapy and possibly one-on-one therapy. I would also include the patient's flat affect, that she was withdrawn and quiet, and that her behavior wasn't quite as appropriate as it should be. And there are places in the EMR where you can add those notes. So how do we document goals? What goals should we focus on? Well, based on the initial evaluation, I would suggest we focus on her deficits, specifically her coping skills, problem solving, self-esteem, goal setting, stressor identification, and leisure. Of course, we can always change or adjust the goals as necessary throughout her stay. Goals would appear in the documentation as follows. Patient will demonstrate 2 appropriate coping skills by discharge. Patient will demonstrate 2 effective problem-solving skills by discharge. Patient will develop 1 60-day goal and 1 6-month goal by discharge. Patient will state 2 appropriate positive traits about herself in the group setting by discharge. Patient will identify at least 2 stressors and suggested coping skills to address them by discharge. And the patient will identify 1 new leisure activity to engage in that includes other people by discharge. Documenting a group session. So how did Donna do in her first group session? Well, the next day, Donna joined our group session. That day, our group was just one thing, during which we go around the room talking about just one thing to answer some conversation-starting questions. For example, I'll ask everyone to give me just one thing that they enjoyed in this past week, just one thing they're proud of in their life, just one thing they see as a goal for the next 6 months, just one thing they can do in their free time, and so on. We talk about our responses and why they are important to keeping us healthy in mind and in body. So patient's group notes include a section for how the patient performed in the group. Specifically for Donna, I might write, patient participated in OT group session today. Poor eye contact, did not interact with peers. Offered short answers only when addressed directly. Did not offer spontaneous comments. She did say that she is proud of her son, who is an accountant. One-on-one therapy. Here's a little bit of an exception to what we do. I want to mention briefly one other type of documentation that we need to provide. When a patient refuses to attend a group session or is unable to attend, we sometimes offer one-on-one counseling in their room. This type of therapy usually involves a one-on-one presentation of the same topic discussed in the group session. We simply ask the patient the same questions, but provide one-on-one discussion so that the patient still receives the benefit of the information presented in the group. The EMR does have a section to document one-on-one sessions. The information provided may look very similar, such as patient unable to attend group today due to meeting with the case manager. One-on-one therapy provided in patient's room. Patient had poor eye contact, offered short answers only when addressed directly, did not offer spontaneous comments. She did say that she is proud of her son, who is an accountant. Let's take a look at another case study. This one involves Michael. Michael is a 73-year-old retired maintenance worker who was admitted on a voluntary basis after telling his psychiatrist he wanted to kill himself. He had a plan to go to the top of a parking garage and jump off. He has a history of major depressive disorder and anxiety. He was hospitalized for the same only once, 20 years ago. Upon entering the room, the patient is sitting at the edge of the bed, staring out of his window, in deep thoughts. He is hard of hearing, uses a rolling walker due to arthritis in his knees. He requires moderate assistance to don socks and shoes, and minimal assistance for upper body dressing due to a shoulder replacement 10 years ago. He is independent with other ADLs. He lives with his wife, who helps with his dressing, and he stated he's afraid he's starting to become a burden to her. He presents with a flat affect, poor eye contact, and speaks loudly and seems agitated. Some of the statements that Michael makes in your presence include, "What do you want? I don't need therapy. I made a mistake coming here. I just need a break." As part of your evaluation, he also provides the following information. His reason for admission: "I wanted to end it all." His stressors: "I just don't want to do it anymore." His strengths: "Well, I guess I can fix just about anything." His weaknesses: "Nothing." What does he do in his leisure time? "I just sit and watch TV. I can't do anything else." His goal: "I want to go back 30 years when I was strong. Can you make that happen?" He took the SLUMS test and scored a 22, indicating mild neurocognitive disorder. Now let's put it all together. Please answer the following questions. What is your general observation of this patient? How would you describe his behavior, affect, his participation, and general well-being? Develop statements for each section of the SOAP note, including subjective, objective, assessment, and plan. What difficulties, mental and physical, do you see this patient having that may prevent him from living independently? Let's assume he will be an inpatient for 30 days. Please develop 2 ADL-related goals and 4 mental health-related goals you would like to see him achieve during his stay. Describe a general 50 to 60-minute group session that you can conduct to address one or more of the patient's mental health-related goals. Please have fun with this and try to be creative. If you want to work in pairs or small groups, feel free. Bounce ideas off each other. See what you can come up with. Thank you very much for your attention. I hope you learned a little about documentation in the mental health care setting, and I hope you have the opportunity to work in this setting someday. It really is quite rewarding. Please see the references for more information and resources on this topic. Again, thank you.